بسم الله الرحمن الرحيم. This is the second part of temporal bone pathology differential diagnosis. Alhamdulillah wa salatu wa salam ala rasulullah wa ala alihi wa sahbihi wa sallam ajma'in. Allahumma anfa'ni bima 'allamtani wa 'allimni bima yanfa'uni wa zidni 'ilman innaka al-'alimul hakim. Allahumma akhrijna min dhulumatil wahm wa akribna bi nuril fahm وافتح علينا بمعرفة العلم وسهل أخلاقنا بالحلم آمين وأجمعين. اللهم ارزقني نعمة الإخلاص لوجهك الكريم بكل ما أقول وبكل ما أفعل آمين يا رب العالمين. I will start my talk about the temporal bone pathology differential diagnosis with anatomic variants. The anatomic variants can be classified to facial canal dehiscence, semicircular canal dehiscence, bulging sigmoid sinus, aerated petrous apex, high jugular bulb, and dehiscence of the jugular bulb. Facial canal dehiscence. The bony facial canal is dehiscent and the facial nerve is exposed to the middle ear cavity, making susceptible to infection and trauma, and it is most common in the tympanic segment of the facial nerve. As we see here, there is dehiscence of the facial nerve on the right side comparing to the left side, and also here there is a chronic otitis media on the left side. Here facial nerve, another case of facial nerve dehiscence, and we see lack of bony of facial canal in the lateral side of the horizontal of the facial nerve. Semicircular canal dehiscence, and it is mostly seen in the superior semicircular canal and present with Dolio phenomenon, which is composed of vertigo, nystagmus, and induced by loud noises. And the CT scan, it is best seen on the coronal view. Sigmoid sinus, bulging of the sigmoid sinus protrude into the mastoid, can get accidentally injured during the mastoidectomy. As we see here, the sigmoid sinus, it is bulging along the posterior wall of the mastoid. Aerated petrous apex may undergo petrous appendicitis as a complication of chronic otitis media. Gradenico syndrome, it is a retroorbital pain, petrous appendicitis, and abducent nerve palsy. As we see here, it is bilateral petrous apex pneumatized, as we see here and here. High jugular bulb, dome of the jugular bulb extend more superiorly in the petrous temporal bone, and bosses hazard during ear surgery. If not detected preoperatively, a transverse level above which jugular bulb is considered high riding is floor of the internal acoustic meatus, floor of external auditory canal, basal turn of the cochlea. As we see here, we have high jugular bulb in this axial CT scan with superior extent of the jugular bulb, as we see here, at the level of the basal turn of the cochlea. Dehiscence of jugular bulb, absent of separation between the jugular bulb and the tympanic cavity. As we see here, this is the dehiscence of the jugular bulb in the case of high jugular bulb. And we see the jugular bulb, it is dehiscent with in contact with the middle with the tympanic cavity as we see here. Let us see the pathology of the temporal bone. We can classify the pathology of the temporal bone to congenital, traumatic, inflammatory, infectious, cholesterol granuloma, postoperative imaging, autosclerosis, tumor, and miscellaneous condition. In the congenital, we have the microtia or anotia or congenital cholestatoma. In microtia or anotia, it is failure of canalization of the external auditory canal will lead to atresia. As we see here in this axial CT scan, bilateral external auditory canal are not canalized and hyperonematized of the mastoid air cells are noted at the level of the cochlea. In this CT scan, coronal image, the non-canalization of the bilateral auditory canal. And here in the axial image shows bilateral MICROTIA with stenosis of the external auditory canal. And here also MICROTIA with in this axial CT scan with some dysplastic ossicles. Congenital cholestatoma, and it is congenital ectoderm means that a congenital ectoderm rests skin in the wrong place, is left behind the middle ear cavity, and it is 5% of cholestatoma, and it is location in the anterior superior tympanic cavity near the Eustachian tube or posterior epitympanum as tympanic smile. And here in this patient with congenital cholestatoma, in this axial CT scan, we saw soft tissue density as seen in the arrow in the middle ear cavity and the mastoid air cells with no bony sclerosis or erosion, and increased soft tissue density in the temporal bone, likely developing the abscess. Traumatic region, we have patient presented clinically with hemorrhagic otorrhea, hemotympanum, and tympanic membrane perforation with hearing loss with the cranial nerve 7 palsy, with battle sign, post-auricular ecchymosis from traumatic rupture of the mastoid emissary vessels. We have the longitudinal and the transverse fractures. The longitudinal fracture is more common than the transverse fracture and result in ossicular and tympanic membrane injury, as we see here in this axial CT scan horizontal fracture of the right ear extended from the temporal region to the middle ear cavity, as we see here. Transverse fracture, it is less common and it presented about 10 to 20%, and is a fracture is perpendicular to the petrous bone, and it is high risk of facial nerve injury. As we see here in this axial and coronal cuts of the CT scan, we have a fracture extended across the petrous bone, as we see here, and with across the middle ear cavity, as it is across the middle ear cavity, and this is the fracture line. Inflammatory, infectious, we have acute otitis media, acute otitis media with abscess, or chronic otitis media with ossicular erosion, and acquired cholesteatoma and cholesterol granuloma. Acute otitis media with active infection in the middle ear and mastoid ear cells without destruction of the mastoid septation or cortex. Patient presented with otalgia, otorrhea, headache, fever, and in the imaging we have ossification of the middle ear and the mastoid ear cells with soft tissue and erosion of the mastoid septation to distinguish the coalescent and non-coalescent mastoiditis. As we see here in this axial cut, CT scans of tissue density in the mastoid antrum with and the mastoid middle ear cavity with bony the bony ossicles are appear normal. No sclerosis in the mastoid seen. Acute mastoid, acute otitis media with abscess, and the CT we have RM enhancing fluid collection adjacent to the mastoid uh, air cells and ossification. And as we see here, we have cerebellar abscess in this axial CT scan, soft tissue density in the middle ear cavity, and mastoid antrum cavity extended to the cerebellar region. MRI show the enhancement of the abscess. Chronic otitis media with ossicular erosion, erosive changes involving the ossicular chain in absence of cholesterol, and patient have conductive hearing loss. As we see here in this patient, we have a chronic otitis media with ossicular destruction on the left side, with axial and coronal cut. We have bony destruction of the ossicles on the left side, as we see here in this here, associated with soft tissue. And we have no ice cream cone of seen because it is eroded. And two parallel lines noted due to dehiscence of the semicircular canal, lateral semicircular canal. Acquired cholesteatoma, it is exfoliated keratin within stratified squamous epithelium, and it is patient presented with the chronic ear discharge with tympanic membrane retraction and perforation. We have two types, Bars flaccid variant and Bars tensor variant, and we have a mural variant. with the complication of the acquired cholesterol, cranial nerve 7 involvement, venous sinus thrombosis, intracranial extension with abscess, cephalocele, chronic fistula, and middle cranial fossa infection and chronic osteomyelitis. As we see here in this patient, axial and coronal cuts shows dehiscence of the facial nerve canal, as we see here, and with patient with a chronic otitis media on the left side. Here, this patient with mural cholesteatoma with axial and coronal cuts shows soft tissue mass with erosion of the external auditory canal, automastoidectomy. Here, complication of a chronic otitis media, chronic osteomyelitis, and with axial and coronal images. We see fluffy periosteal reaction with sclerosis of the adjacent mastoid bone in this case. Here, another complication with temporal lobe abscess, as we see here, with destruction of the bone with axial and coronal cuts and axial and coronal cuts after CT enhancement, contrast enhancement. Here, another complication with post-auricular fistula uh, in the axial and coronal cuts with destruction of the ossicles and cavity formation in the middle ear, which open in the post-oral region, as we see here. Cholesterol granuloma, also cholesterol cyst, known as cholesterol cyst or chocolate cyst or blue domed cyst. And it is location in the middle ear or petrous apex, and patient presented with a progressive hearing, slowly progressive hearing loss, autopsy, non-pulsating bluish discoloration of the tympanic membrane, a blue eardrum. And imaging, we have expansile lesion within the imperceptible bone margin, high signal in both T1 and T2. As we see here with cholesterol granuloma with axial and coronal CT scan shows non-enhancing mass uh, causing bony expansion of the temporal bone without obvious anechoical breach. Post-operative imaging, we have the mastoidectomy, we have the canal wall up, canal wall down, and radical mastoidectomy. Canal wall up, accentration of the mastoid air cells with the preservation of the posterior wall of the external auditory canal, creating mastoid cavity. Canal wall down, canal wall up, plus resection of the posterior wall of the external auditory canal, radical mastectomy. It is involved the canal wall up and removal of the tympanic membrane, malus incus, and the preservation of the stapes. Mastoid cavity should remain clear. A presence of soft tissue represents a granulation or inappropriate clinical setting, cholesteatoma. MRI is done in such cases with T1, T2 post-contrast and ecoplanar diffusion weighted images sequence. As we see here in this patient, axial and coronal cuts, post-canal wall down. It is mastoidectomy. Changes is common. Cavity between the external auditory canal and the mastoid cavity, and posterior wall of external auditory canal is not seen because it is canal post canal wall down. Coronal image shows the post-operative changes of the post-canal wall down procedure. Here, another patient with tympanomastidectomy. Patient presented with recurrent ear discharge with axial cut CT scan, and we see soft in tissue in the middle ear and mastoid antrum of the left side with destruction of the bony ossicles, possibility of recurrence or residual granulation tissue was considered. MRI is advised for better evaluation, and we see with the MRI T1 weighted image has hypodensity in the left temporal bone as compared to the right side, and T2 has hyperintensity with diffusion, show no restriction with corresponding high ADC values. So this is a granulation tissue. Post-operative imaging staples prosthesis. It is done in cases of conductive hearing loss due to otosclerosis or congenital anomalies, and it is consist of lobe attached to the lentricular process of the incus. Piston sits in groove formed by stable foot plate, and it is complication, migration or dislocation or fracture or recurrent cholesteatoma, procedure erosion of the ossicles, and lymphatic fistula. As we see here, this axial cut CT scan, we have the stapes prosthesis with hyperdense linear density notice extended from the incus to the oval window. This is the stapes prosthesis. Otosclerosis, it is common bilateral in about 85% with female predominance, 65 to 72. We have dense middle ear layer and endochondral bone resolved, replaced by spongy vascular bone. Patient has loss in the second to fourth decade hearing loss, and it is location we have fissure anti-fenestrum just anterior to the oval window. We have the fenestral type and retrofenestral type. As we see here in this patient, we have the fenestral otosclerosis in the right ear, and we have hypodensity in the region just superior to the oval window, as we see here in this our oval window reach. Left ear is normal, so hypodensity in this area over superior to the oval window niche. Here, fenestral otosclerosis with oblique axial cuts shows the stapes as we see here. It is foot of the stapes attaching to the oval window niche in this area. Labyrinthitis ossificans, we have a fluid-filled lumen of the otic capsule replaced by bone or fibrous tissue in the early stage patient with sensory and neural hearing loss and loss of the vestibular function. High resolution density, bone deposition in or around the inner ear. As we see here, comparing the left side with the right side, and we see here labyrinthitis ossificans, both chronic otitis media, axial cut, as we see here, hyperdense cochlea, as we see compare here the basal term with the basal term, hyperdense cochlea in the left ear with hypodensity in the middle ear, as we see, cavity and sclerosis of the mastoid ear cells. Right ear is normal cochlea. So sclerosis, hypodensity in the middle ear with the sclerosis of the mastoid ear cells. Tumor and the tumor-like condition, we have external ear squamous cell carcinoma, external ear hemangioma, external auditory canal polyp, external ear squamous cell carcinoma. It is the most common, and we have, as we see here in this axial CT scan, and we have hypodensity mass lesion involving the external ear and causing destruction of the temporal bone, which is heterogeneous with soft tissue enhancement after contrast biopsy. It is proved to be squamous cell carcinoma. External ear hemangioma, it is rare, and most hemangioma involving the entire external ear canal, as we see here, mass lesion involving the mass lesion in the axial and coronal cuts before and after contrast, hypodense mass or lesion in the external auditory canal with enhancement and wash out on the venous and delayed, similar to the surrounding arteries. Polyp, this is external auditory canal polyp. It is due to chronic inflammatory forms, overgrowth filled with granulation tissue, usually not associated with bony erosion. As we see here, the polyp in the external auditory canal. Middle ear tumor, we have the glomus tympanicum and the glomus jugulotympanicum and middle ear rhabdomyosarcoma. Middle ear neuroendocrine tumor, we have, as we said, glomus tympanicum or glomus jugulotympanicum seen, and we have here mass lesion in the glomus middle ear region with enhancement. Middle ear rhabdomyosarcoma, it is soft tissue sarcoma. It is in children. 50% occur in the head and neck region. As we see here, we have axial and coronal cuts with and without enhancement, and we see aggressive lesion causing destruction of the bone, of the temporal bone, with the sparing of the cochlea, as we see here. Involved in the left side with heterogeneous enhancement, and biopsy it is rhabdomyosarcoma. Miscellaneous condition, we have the budget disease, and we have the bone dysplasia, and this patient have late budget disease, as we see in this axial CT scan bone window involving the frontal and bilateral otic capsule region and generalized osteopenia with cortical thickening. And this patient with osteopetrosis or another miscellaneous condition. It is osteopetrosis and it is autosomal recessive, occurs in children and can have more than one type 1, type 2, and here this is a patient with osteopetrosis and this axial CT scan cut with dense bone, diffusely dense bone called chalky white bones. Thank you for listening and hoping to see you soon in another talk. This is a shortly talk about the temporal bone pathology differential diagnosis in a short book in a short talk. Hoping you like it and see you in another talk soon. Thank you very much. سبحانك اللهم وبحمدك أشهد أن لا إله إلا أنت أستغفرك وأتوب إليك.